This is Aiden Scott, Program Manager, Lead Instructor for EMS University San Antonio. We're now going to go over Lesson 4.7, Environmental Emergencies. There are certain factors that affect exposures. Physical condition being number one. Patients who are ill or in poor physical condition won't tolerate extreme temperatures very well. Um, Age is another factor. Uh, Infants have poor thermoregulation and are unable to shiver. Uh, Children may not think to put on layers. Older adults lose subcutaneous tissue and also have poor circulation. This makes it difficult for them to thermoregulate as well. Nutrition and hydration. A decrease in either will aggravate either hot or cold stresses. Alcohol also changes the body's ability to regulate temperature as well. The environmental conditions, conditions that can complicate or improve environmental situations, air temperature, humidity level, wind. Any extremes in temperature and humidity are not needed to produce injuries. Most hypothermia occurs at temperatures between 30 and 50 degrees Fahrenheit. Most heat strokes occur when the temperature is 80 degrees Fahrenheit and the humidity is 80%. Uh, you have to examine the environmental temperature of your patient in order to help determine whether they're having an environmental exposure issue or not. Um, I know here in South Texas we have a lot of this occurring, even when the temperatures, as stated earlier, are only in the 80s. But we also have many days with 80, 90, even 100% humidity. So you always have to be aware of what the environmental temperature is wherever you're at. There are 5 ways the body can lose heat. There's conduction, convection, radiation, evaporation, and respiration. Now let's take a look at hypothermia. Hypothermia is a lowering of the core temperature below 95 degrees Fahrenheit or 35 degrees centigrade. The body loses the ability to regulate its temperature and generate body heat. Eventually, key organs such as the heart begin to slow down. It can lead to death if it continues untreated. Care of hypothermic patients is most critical within the first 30 minutes. This 30-minute window is very, very critical uh, simply because at that point, too much tissue damage is done. Organ systems have already shut down, so you have to really push to get a hypothermic patient treated within the first 30 minutes of exposure. There are classes of hypothermia. You have mild, which is 95 degrees Fahrenheit to 90 degrees Fahrenheit. This is mild to moderate shivering, rapid respirations, and pulse. They'll have numbness in the fingers and toes. At about the 90-degree Fahrenheit mark, confusion starts to set in. The patient may start to stumble, slur their speech, etc. Their extremities will either be red, pale, or blue. The patient may also still be alert, but not very oriented. Moderate hypothermia is when the body temperature is between 85 and 90 degrees Fahrenheit. The patient will be very lethargic, sleepy. Their pulse will be very, very slow. They won't have any fine motor dexterity. They probably won't be able to ambulate on their own. Their extremities will be pale and or blue, and these folks generally can't shiver anymore at this point. Severe hypothermia is 80 degrees Fahrenheit and below. This is when the patient goes into a coma. They're extremely irrational if they are still alert. Very slow respirations. You'll notice a lot of cardiac arrhythmias as well. Below 78 degrees Fahrenheit, the patient is clinically dead. They'll be unconscious, apneic, and pulseless at this point. The body can no longer function. However, the patient is not dead until they are warm and dead. So their body temperature has to be elevated to, uh, I guess, a warm status, if you will, before they can technically be pronounced dead. Local cold injuries. Most injuries from the cold are confined to exposed parts of the body. Uh, Important factors in determining the severity of a local cold injury are duration of the exposure, temperature to which the body part was exposed, and also the wind velocity during the exposure. You should also investigate a number of underlying factors as well. Exposure to wet conditions, inadequate insulation from the cold or the wind, restricted circulation even from tight clothing or shoes, or even an underlying circulatory disease. A fatigued patient, drug or alcohol abuse will also be a very big factor. Any predisposed hypothermia. Diabetes will cause very big problems with your cold exposures, as well as cardiovascular disease. Also, your older patients are more prone to your cold exposure injuries. So, when you have a hypothermic patient, it's always good to investigate, get a very detailed medical history if possible, because any or all of these factors could be playing a big part in your patient's status. Here we're looking at some cold injuries. You note the blistering, swelling, the redness to the toes in the middle picture. Um, this is what just a cold injury could potentially look like. Let's look at frost nip and immersion foot, uh, or trench foot. Uh, these have similar signs and symptoms. The skin is pale and cold to the touch. Uh, when you palpate the skin, the normal color, the normal flushing color doesn't return. The skin of the foot may be wrinkled, but it can also remain soft. The patient will also report loss of feeling and sensation in the injured area. Fingers and toes are usually the worst when it comes to this. Trench foot is a very real, very serious problem. So if your patient has been exposed to the cold or wet, and they're complaining of losing feeling in their feet, you should really look at trench foot because it can be very detrimental in the long run. Frostbite is the most serious local cold injury because the tissues are actually frozen. Gangrene, the affected area will then become gangrenous, and that requires surgical removal of the dead tissue, usually of the limb or extremity or the affected area. You see here the fingers are black. These fingers have been frostbitten, and this patient will probably lose at least all of their fingers, if not their hands as well. The signs and symptoms, the fingers, as you can see, have a hard, waxy look. They feel firm because they are frozen as you touch it. Blisters and swelling may be present, but it's all dependent on your patient, really. In light skinned individuals with a deep injury, the skin may appear red with purple and white or a mottled cyanotic look. The depth of the skin damage will vary. With a superficial frostbite, only the skin is frozen. However, with a deeper frostbite, the deeper tissues are frozen. This includes your muscle tissue, as well as your blood vessels and all that. However, in the field, you may very well not be able to tell the superficial from the deep frostbite. That's something that takes usually imaging to determine. Your scene size up considerations, you need to note the weather conditions. Obviously, they are going to have a very large impact on your treatment. You also want to identify any safety hazards such as icy roads, mud, even wet grass. You need to look for indicators of the mechanism of injury. Also consider how the mechanism of injury produced the injuries expected. Uh, so, take your mechanism of injury and look at what injuries you would expect to see, um, and make sure your patient fits that profile. Your assessment um, is going to vary a little bit. Uh, if your patient's got LOC, are they an altered LOC? Is that due to the environment, or is there something else going on? Your airway and breathing, your patient should be getting warmed, humidified oxygen. This helps warm the patient from the inside out. Your circulation, you need to palpate carotid pulse and wait for 30 to 45 seconds to decide if they're pulseless. Sometimes the heart rate will slow to, no more than 10-15 beats a minute. So you need to, really, really wait quite a while, just to make sure that the patient is in fact pulseless. The American Heart Association does recommend that CPR be started on a patient who has no detectable pulse or breathing. However, with your uh, environmental uh, exposures, the perfusion is obviously going to be compromised, so you need to be careful. The skin will not be helpful in determining shock, obviously, because it's already going to be pale or cyanotic due to the environmental factors. Any bleeding may be difficult to find simply because the circulatory system has, in effect, shut down or slowed down to a point to where bleeding may not be immediately evident, as you would find with a warmer patient. Your transport decisions, obviously, your hypothermic patients are going to require immediate transport, simply because they need pretty severe warming. One, two, they need to be evaluated for tissue and organ damage, and that can only be done in the hospital. You do, however, need to assess the scene for the safest and quickest way to move your patient, even if it requires calling in a specialized team for extrication from the area. Always be aware of what you're looking at, where you're at, and also what resources you have on hand to help you get this patient out as safely as possible. Your sample history, you need to find out how long your patient has been exposed to the cold environment. This is obviously very critical. It's a very critical piece of information. Um, some exposures may be acute, haven't been exposed very long, but some may be chronic. A persistent exposure to the cold will cause hypothermic injuries, and they'll present just the same as an acute. So you need to be aware of, has your patient been um, uh, in the cold weather for a while, or is this a pretty quick thing? You need to try to get a core body temperature as accurate as possible. This is going to be one of the most vital signs that you take. Your pulse oximetry is probably going to be inaccurate, simply uh, because again, your perfusion is not very adequate at all. Your blood flow is not going to be adequate. You do need to be very watchful of any changes in the mental status. It will change very quickly. Um, be aware, though, rewarming can lead to cardiac arrhythmias, so be very aware of what your patient's cardiac rhythms look like. Of course, you need to remove any wet or frozen clothing, even if it remo- even if it means removing all of your patient's clothing, right down to underwear and socks. If it's wet or cold, you absolutely have to remove that clothing. General management of cold emergencies. You need to move the patient from the cold environment, obviously. Do not allow the patient to walk. They need to be carried out of there one way or another. As said before, remove any wet clothing. That includes any undergarments, socks, anything like that. Remove anything that's wet. Place dry blankets over and under the patient. This will help with insulation. If available, give the patient warm humidified oxygen. However, take very good care in handling the patient gently. Some are going to have oversensitized issues. The slightest movement could be extremely painful, so you need to be very careful when handling them. Do not massage the extremities, though. This could cause more damage than help. Do not allow the patient to eat, use any stimulants, or smoke or chew tobacco. Um, they're already going to have cardiovascular issues coming out of this. We don't need to exacerbate that at all. If the patient is alert, shivering, responds appropriately, and the core body temperature is between 90 and 95 degrees, then the hypothermia is pretty mild. You just want to apply heat packs or hot water bottles to the groin, axillary, and cervical regions. You need to take care to rewarm these patients very slowly. You can even give them warm fluids by mouth. Just be sure they're not too hot, just because you don't want the patient to burn themselves. When the patient has a moderate or severe hypothermia, never try to actively rewarm the patient. Passive rewarming should be reserved for an appropriate facility, which means you need to get them out of the elements and get them to the hospital pretty quick. The goal is to prevent further heat loss. Again, you want to remove the wet clothing, cover them with a blanket, and transport immediately. One thing to consider, blisters are a protective sign of the body. The body uses blisters to protect itself. Don't pop them. You're going to expose very sensitive tissue and could open the person up for an infection. So leave all blisters intact. One thing to keep in mind is normal body temperature is 98.6. Hyperthermia is when the core temperature is higher than 101 degrees Fahrenheit or 38.3 degrees Celsius or higher. Risk factors are age, health, and mobility. There are 3 levels of heat injury. You have heat cramps, which are indicative of an electrolyte deficiency. You have heat exhaustion, which is the body's way of spending most of its compensatory mechanisms. And then you have heat stroke. This is body compensation gets overwhelmed and it starts to shut down. The body just cannot compensate anymore. The heat stroke signs and symptoms are hot, dry, flushed skin. Emphasis on the dry. Their skin will be arid, very arid, no moisture at all. Heat stroke occurs when the body is so dehydrated that it cannot sweat anymore. Early on, the skin may be moist or wet, but this is usually just left over from their heat injury prior to. The body temperature will be rising very quickly. However, their level of consciousness will be falling very quickly. It often leads to unconsciousness. You also want to look for a change in behavior. Again, they'll be unresponsive pretty quick. Your heat stroke patients are very prone to seizures, so always be on the lookout for those to occur. They'll have a strong, rapid pulse at first, but then it'll become weaker as the blood pressure falls. simply from dehydration. Their respiratory rate will increase. They're trying to blow off some of that heat, that internal heat. Again, there won't be any perspiration. For heat emergencies, the direst sign, which requires rapid transportation, is hot, dry skin. Their skin will be hot to the touch, and there will be no perspiration on it. This is the most critical sign that they need to get to the hospital immediately. So don't wait for anything. Load the patient and get out of there. On these patients, you always need to consider ALS intercepts, just because they can turn south so very quickly. Um, they'll need the advanced intervention. For the heat cramps and exhaustion, you can replace fluid by mouth. You can also cool the patient with a water spray or a mist. Heat strokes, though, you need to actively cool the patient with cold packs in the pulse points, being the cervical area, the back of the neck, the groin, and the axillary area, the armpits. You also want to passively cool with air conditioning and stripping the patient. You only want to strip the patient once they are in the back of the ambulance, obviously for patient posterity. However, you need to watch for shivering because this will cause reflex hypothermia. Shivering is the body's way of trying to produce its own heat. So you need to be very careful. If your patient starts to shiver, you need to figure out a way to get them to stop because you don't need their body temperature rising any more than it already is. For your drownings, immersion, and submersion incidents, the process of experience respiratory impairment from submersion or immersion in liquid. The near drowning is a term that is no longer used in pre-hospital. Spinal injuries and submersion incidents, you should always suspect and therefore treat for a spinal injury in all submersion incidents, unless ruled out during the assessment. Most spinal injuries and diving incidents affect the cervical spine, so you need to be watchful of that and always maintain C-spine immobilization until you can rule it out again by assessment. You need to stabilize the suspected injury while the patient is still in the water. The sea collar should be on them. That backboard will go in the water just fine. So you need to get it on them as quickly as possible. It also helps to maneuver the patient out of the water if you already have them on the backboard. Recovery techniques: if the patient is not floating or visible in the water, an organized rescue effort is necessary. There are specialized diving teams all over the country that do just this. Uh, they have snorkels, masks, and scuba gear. These people have special certifications for rescue diving. So you need to be aware again of where you're at and what resources you have at your availability. As a last resort, a grappling iron or large hook may be used to drag the bottom. However, is that considered a rescue? Um, it is the rescue of the patient's body. However, whether or not you're actually able to resuscitate the patient uh, really is dependent. Never give up on resuscitating a cold water drowning victim. Um, they generally do tend to come around. The mammalian diving reflex may cause immediate bradycardia. If you've got a cold water drowning victim, the body will immediately go into reflex bradycardia. So always be aware of that. You never want to give up on resuscitating a cold water drowning victim. Um, do everything in your power. Get an ALS intercept so that you can so that you can try to get this patient resuscitated. Descent emergencies caused by the sudden increase in pressure as the person dives deeper into the water. Uh, Pain forces the diver to return to the surface quickly to equalize the pressure, and the problem clears up by itself. Um, However, they do perforate the tympanic membrane or the eardrum. Cold water may enter the middle ear through a ruptured eardrum. This will cause the diver to lose his or her balance and orientation, um, and it also uh, could cause ascent issues as well. At the bottom, there are rarely problems. These are usually caused by faulty connections in the diving gear. Um, these obviously can cause the patient to drown, or uh, they can have a rapid ascent, which would cause a great deal of hyperbaric issues. Ascent, Ascent emergencies. You have the decompression sickness or DCS. These are also known as the bends. This is when nitrogen bubbles form in the muscle tissues, which is extremely painful. This may occur from about 12 hours after the dive up to even 72 hours after the dive. So, again, it's always good to get a very detailed history. Um, ascent emerg- Rapid ascents can also cause an air gas embolism or an AGE. It's the same concept as the bends, but more severe. This will actually include CNS depression, as well as stroke-like signs and symptoms. Um, this will occur sooner than DCS. These usually occur within the first 15 minutes post-dive. Treatment is the same for both of these. Just standard BLS protocols, and then recompression in a hyperbaric chamber. For a diving emergency, it is your immediate responsibility as an EMT to administer oxygen and transport the patient to the hospital. Contact medical direction for consultation of a transportation to a recompression chamber. Um, Obviously, you're gonna, put them in your ambulance, administer high flow O2, and head towards the hospital. However, if you suspect or you have proof of an ascent injury, contact your medical director. They may redirect you to a compression chamber. Your safety considerations: always obtain a sample of the water. Um, Bring dive computer, log, and/or equipment if possible. If the patient has it on board on their watercraft, if that's what they were using, um, absolutely bring it with you. Always consider C-spine. Um, any type of water emergency, always, you want to consider C-spine. Um, it's always better to be safe than sorry. Uh, you also want to check for additional patients. Um, there won't always just be one diver. More often than not, you have two, and if there's not a second person standing around in a wetsuit, you probably have a second patient down there at the bottom. A personal flotation device is necessary when working a water rescue scene, and the EMT is within 10 feet of water. In other words, you have to have a life jacket on. Always have a personal flotation device whenever you are within 10 feet of the water, or if you're on the watercraft assisting in the rescue. Uh, always put your safety first. Don't ever go without because it's uncomfortable or it doesn't look cool. No. Put a life jacket on or stay greater than 10 feet from the water. Now we're going to look at high altitude emergencies. First one, or to start, dysbarism injuries. These are the same concept as dive emergencies. Um, Expanding gases really do some work on the body. High altitude illness is diminished O2 in the air at high altitudes, works on the central nervous system and pulmonary system. Um, the body has to work harder to properly perfuse if you're not used to living at a high altitude. This happens frequently. Um, We have acute mountain sickness, which is at an elevation higher than 8,000 feet above sea level. This is caused by ascending too high, too fast, or not being acclimatized to high altitudes. Both do have generalized ill person type signs and symptoms with altered mental status, including possible altered level of consciousness. It's just a more severe case overall. Then you can have a high altitude pulmonary edema. This happens at 10,000 feet or higher above sea level. This is when fluid collects in the lungs, hindering the passage of oxygen into the bloodstream. Your signs and symptoms are going to be shortness of breath, cough with a pink sputum. Your patient is going to be cyanotic, and they're also going to have a rapid pulse. You can also have high altitude cerebral edema. This happens at 12,000 feet above sea level or higher. The signs and symptoms for this are severe constant throbbing headache, ataxia, extreme fatigue, vomiting, as well as a loss of consciousness. Now let's take a look at lightning. Respiratory or cardiac arrest is the most common cause of lightning-related deaths. Electricity wants to find a ground. There will be injury at the strike site, the exit wound, and everything in between. The key is to know your anatomy and protect yourself. If there is lightning striking all over the place, you don't want to be out there. Don't be a hero. Keep yourself safe first. Remember, electricity wants to find a ground. Water conducts electricity. Your body is mostly water. Um, this will kill you. So always be extra careful when you're dealing with this kind of an emergency. Spider bites. The black widow. You see the picture here. This is a female. You just note the red hourglass on the body of the spider. The female is fairly large, measuring approximately 2 inches across. Again, usually black with a distinctive bright red, orange marking in the shape of an hourglass on its abdomen. They're found in every state except Alaska. They do prefer dry, dim places. Um, these bites are usually overlooked. They cause localized pain and symptoms, including agonizing muscle spasms. The main danger is the venom. It's poisonous to the nerve tissues. You can have extensive nerve damage if you let a black widow bite go too long without treatment. Other systemic symptoms include dizziness, sweating, nausea, vomiting, rashes, as well as a tightness in the chest. Um, Difficulty breathing, and severe cramps. Generally, these symptoms will subside over 48 hours. However, emergency treatment consists of BLS for the patient and respiratory distress, as well as rapid transport. A brown recluse spider is dull brown in color and about an inch long. It does have a violin-shaped mark on its back. Lives mostly in southern and central parts of the country, but can be found throughout the continental United States. They tend to live in dark areas. Their venom is not neurotoxic, but cytotoxic. It does cause severe local tissue damage. It will cause tissue necrosis very quickly. Typically, the bite is not painful at first, but it does become so within hours. The area becomes swollen and tender, developing a pale, mottled, and cyanotic center. Generally, the bites don't heal, and surgery is needed to stop the centrifugal necrosis. Bees, wasps, ants, yellow jackets all fall under the Hymenoptera stings. Their stings are painful, but usually aren't a medical emergency. You can remove this stinger and venom sac using a firmed edged item such as a credit card to scrape the stinger and sac off the skin. However, they do become a medical emergency when anaphylaxis occurs because the patient's allergic to the venom. This is becoming more and more of an issue nowadays, so always be aware. your patient may very well end up having an anaphylactic reaction to a bee, wasp, ant, or yellow jacket sting. Snake bites, it's always, always, always vital to try to find out the species of the snake that bit the patient. This, in turn, will help, one, to determine what kind of symptoms your patient's going to have, as well as what antivenom they're going to need. However, scene safety is a must. The snake may still be hanging around. You don't want to become his snack too. Uh, Dead snakes can still bite. Most people don't believe it, but they can, and they will. You have to be very careful. Also, you want to know the size of the snake. Most people don't believe it. Rattlesnakes, um, their babies, the smaller rattlesnakes, are actually, their venom is much more potent than an adult rattlesnake. So size does matter. You have to be aware of what you're looking at and what you're looking for. Signs of envenomation are severe burning pain to the site of the injury, swelling and bluish discoloration, weakness, nausea and vomiting, sweating, seizures, fainting, vision disturbances, change in LOC, as well as shock. You need to calm the patient down. First and foremost, calm the patient down. Locate the bite area and clean it gently with soap and water if available. If the bite occurred on an arm or a leg, splint the extremity to decrease the movement. Be very alert for the patient to vomit. Do not give anything by mouth, not even a sip of water. If the bite occurred on the trunk, keep the patient supine and quiet and transport as quickly as possible. Also, if the bite occurred on an extremity, keep it angled below the heart. This makes it more difficult for the venom to get to the heart and to the brain. So you want to slow that venom movement through the vascular system as much as possible. If there are any signs of shock, treat it. If the snake has been killed, bring it with you. Again, be very careful. Usually, put it in a box. Don't bring a snake by itself out in the open. Like I said earlier, dead snakes still bite. Put it in a box, put it in Tupperware, put it in something that creates a barrier between you and the snake. Notify the hospital that you are bringing in a patient with a snake bite. Transport properly and patch. Transport promptly and patch. Rapid transport, priority one. Don't take any time on this one. The quicker they get to the hospital, the quicker they can get the antivenom agent. The more likely they are to survive with minimal effects of the bite. Scorpions, you see a nice one here. This is most commonly found in the continental United States. They are 8-legged arachnids with a venom gland and a stinger at the end of their tail. They are rare and live primarily in the southwestern United States and in deserts, and apparently in Gilbert, Arizona. With one exception, a scorpion sting is usually very painful but not dangerous. The exception is the I'm not even gonna try that one. Bark scorpion, which is apparently in Arizona. The venom may cause circulatory collapse, severe muscle contractions, excessive salivation, hypertension, convulsions, and cardiac failure. One more thing about the scorpions, unless you do live in Arizona and are exposed to the bark scorpion, those other little brown guys are, while they are venomous and yes, the bites hurt, they are non-lethal. They, uh, unless, of course, you have some sort of anaphylactic reaction to it. Now let's talk about ticks, everybody's favorite parasite. These insects usually attach themselves directly to the skin, found most often in brush, shrubs, trees, sand dunes, and other animals. Only a fraction of an inch long. The bite isn't painful, you don't even feel it, but it can spread, infecting organisms in its saliva. One of the biggest things ticks are known for is Lyme disease. Tick bites occur most commonly during the summer months. Transmission from tick to person takes at least 12 hours. Don't attempt to suffocate or burn the tick. You will probably burn yourself. Using fine tweezers, grasp the tick by the body and pull it straight out of the skin. Um, Paint the area with a disinfectant. You want to really, 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 really disinfect this area just to make sure that anything that it was passing to you doesn't stick around. Tick bite complications. Rocky Mountain spotted fever. This occurs within 7 to 10 days after the bite. Symptoms include nausea, vomiting, headache, weakness, paralysis, and cardiorespiratory collapse. And as I said before, Lyme disease is reported in 35 states. The first symptom is a rash that may spread to several parts of the body. It usually begins about 3 days after the bite. In about a third of the patients, the rash usually eventually resembles a target bullseye pattern. You will also notice extremely painful swelling of the joints. Now let's look at marine animals. We've got a picture of the jellyfish, the Portuguese manowar, and the sea anemone. Coelenterites are responsible for more envenomations than any other marine animals. These include fire coral, Portuguese manowar, sea wasps, sea nettles, a true jellyfish, sea anemones, true coral, and soft coral. The signs and symptoms are very painful reddish lesions in light-skinned individuals, headache, dizziness, muscle cramps, and fainting. Emergency treatment for these envenomations limit further discharge of nematicides by avoiding fresh water, wet sand, showers, or careless manipulation of the tentacles. Keep the patient calm and reduce the motion of the affected extremity, and inactivate the nematocysts by applying vinegar. Remove the remaining tentacles by scraping them off with the edge of a sharp, stiff object. Persistent pain may respond to immersion in hot water. Provides transport immediately to the nearest emergency department. This concludes Lesson 4.7, Environmental Emergencies. If you have any questions, please